Good afternoon, everyone. Welcome to the April Coffee Chat. I can't believe that it is April. Um, Hopefully that means that soon we'll be done with pollen here in the DC area, and that crusting of yellow covered on my car, um, in particular for those affected by allergies. We have an amazing panel of advocates today talking about the power of data, and in particular, the power of data and stories to inform policy solutions and to hopefully drive change. Um, we're going to introduce the panel in a second, but in preparation for the panel, I just looked at some of the amazing studies and research that all of you have put together over the years, and there were just a couple of things that really stuck out to me. I just wanted to open up with that. So, for instance, for Anna from the Arthritis Foundation, a survey that I saw relatively recently from you all, finding that more 50% of the patients you surveyed had to go through step therapy and had to go through two or three different drugs before they were able to get the drug that was prescribed to them. And 39%, I think, of 39% of those cases, then the step therapy was stopped because it was ineffective, and another 20% because it even worsened the condition. So I think this data is just so compelling. And how can you not support policy solutions that try to address this to make sure that patients have access to the therapies that are actually prescribed to them? Amy from the PAN Foundation, looking at one of your recent surveys and really finding that 48% of patients that had health insurance and chronic diseases experiencing challenges accessing the therapies that they needed for a variety of reasons. And I'm sure you'll go through a lot of those details. But if you see the magnitude of the challenges that our patient population is experiencing, I don't know how you cannot take action. Then, Kristen, I know ACS CAN is doing an amazing number of different surveys and studies and research. And just one of the things that stuck out to me was looking at the recent study you did on the relationship of 340B in oncology care, and really finding some strong evidence that seems to suggest much bigger margins for 340B hospitals compared to non-hospitals. And again, you will be able to analyze the data much better than I can. But I think it really reinforces for me how important data is to inform policy change. And that's why we're all here today. With that, let me briefly introduce myself. For those who don't know me, I'm Karen Holtz. I'm the Senior Director of Patient Advocacy here at BIO, which means that I get to work with amazing advocates like you all every day, which is a real blessing. And I have four amazing panelists here with me today that I will ask to introduce themselves and their organization in a second. Anna, Christy, Michelle, Amy, thank you so much for being here. Maybe to start us off, Amy, do you want to get started and talk briefly about what the PAN Foundation is, and maybe highlight one of the amazing data sources or reports that you have compiled that you think really has made a difference in changing policy?
Great. Happy to do so, Karen, and thanks for the invite today, and good to see all of you. For those of you not familiar with the PAN Foundation, we are a national charitable foundation and advocacy organization on a mission to accelerate access to affordable, equitable healthcare. And we do that through what we describe as our three pillars. One is financial assistance. The second is advocacy, and the third is delivering education to patients and providers. And couldn't agree with you more, Karen. I think when it comes to policy, having data is so important. I was at a recent NHC leadership meeting where someone said, data makes you credible. Stories make you memorable. And I think the combination of data and patient stories is extraordinarily powerful. So let me share. Hopefully everyone can see that. I just have a couple of slides. About a year ago now, the PAN Foundation launched its Center for Patient Research. And really, the bottom line here is to be able to poll patients who are living with serious illness, chronic conditions, rare diseases, to gain their perspectives and experiences when it comes to their health care, and importantly, the challenges that they face accessing the care they need. We do this in a number of ways. You referenced, Karen, some data from our State of Patient Access, so I'm going to use that as my key example, but we do a lot of national polling. We do rapid polling as well, which enables us to tack on to already existing omnibus polls some questions that really give us the opportunity to hone into specific topics that are timely or important because of something perhaps going on in the legislative or regulatory environment. So back in 2024 was when we launched our State of Patient Access Initiative. What this is a national poll of adults living with chronic conditions across the country. The survey, and it was an online survey, we worked with credible research firm, the Harris Poll team, to help us field this poll. We created a very robust questionnaire, many questions that were categorized into these 5 dimensions. Overall access to care, which spoke to the quality of care that people were receiving over the last 12 months, their relationship and trust with their healthcare professionals, affordability of prescription medications, access to treatment through healthcare plans, and financial toxicity. So earlier this year, we unveiled the 2025 findings, and the overall grades are abysmal. The overall, if you look at all the 5 dimensions, and we came up with a rigorous methodology so that we would be able to say people in the country living with chronic conditions rate access to care with a grade. Well, it was an overall C, and it was C in 2024. We haven't made much progress. What we found interesting this year, and disappointing, is the middle one, affordability of prescription medications. While the letter grade remained the same, that numerical grade dipped, and it was statistically significant. So more people are having problems accessing their prescription medications. I see a little typo there. Probably not a surprise to anyone on this call that there are challenges affording and accessing medications. The statistic that you quoted, Karen, was from the access to treatment through healthcare plans dimension, which got a grade of D- for both years. And when you take those 2 dimensions and kind of reflect on the findings, it contributes significantly to that 5th dimension, which is financial toxicity, which speaks to the financial side effects that people who are living with chronic conditions are facing. And that dimension, that score dipped a lot between the 2 years, a lot of which is maybe contributed to a growing medical debt burden on behalf of patients. As we looked into that access to treatment through healthcare plans dimension, there are many contributing factors here, from prescriptions, medications simply not being covered by plans, high deductibles, step therapy. We're seeing issues here that kind of speak to alternative funding programs, maybe maximizers as well. And this is just a snapshot. The work that Anna's doing, may show much higher percentages, of course, in step therapy. But this is the kind of data that for us at PAN, and perhaps for all of us on the call, it validates the policies that we're already advocating for. It may point to additional policy that we need. And additionally, for us at PAN, it also helps us think through what additional education do patients and healthcare providers need. So I could go on for a long time talking about the state of patient access, but I'm going to stop here and turn it back to you, Karen.
Fantastic. Thank you so much. And what a great way to start talking about the challenges and the power of data. Um, Kirsten, do you want to go next and talk about the important work that ACS CAN is doing to provide data to inform policy, in particular for the oncology community?
Sure. Thanks, Karen. Hello, everybody. First of all, I want to echo what Amy said about the importance of both hard data and patient stories, because I think the two are really important to tell the story. I'm Kirsten Sloan. I'm the policy director for ACS CAN, the American Cancer Society Cancer Action Network. We are the advocacy arm of the American Cancer Society. And our public policies are based on evidence and science. So data plays an incredibly important role for us. And the data helps to shore up the stories and the advocacy work that we're doing. And then we couple that with patient stories. We have volunteers nationwide. And there's nothing more powerful, frankly, than walking into a policymaker's office with hard data and then the individual whose story backs up that data. It's hard to look somebody in the eye and tell them that you don't agree with them when they've got the data and their story right there. So we use, as Amy does, we use hard data sets, but we have what I would call a very unique data set as well, and that's something called Survivor Views. It is a cohort of cancer survivors, and we survey them several times a year on a range of policy issues. So we get real-time feedback from cancer patients who have experienced the kinds of policy problems that we're trying to solve. And they help to influence us and inform us in terms of how our policy solutions might work, whether our solutions are realistic or not. Most recently, we've talked to some of our that cohort about affordability. And we know that that remains an enormous issue, both on the treatment side and on the drug side, but also on the prevention side. We're worried about the Braidwood case and what that would mean for no-cost preventive services, for instance. They've also talked to us a lot about medical debt and what that means to a patient, even those with insurance. So they look to us to develop policies on keeping healthcare affordable. They help to influence the work that we're doing, and we couple that anecdotal survey data with some of the hard data to make those cases. Karen, back to you.
Fantastic. Can't wait to dive deeper. But before we go there, Anna, you represent the arthritis community. And I know you've done amazing work both on the policy front and on collecting and providing data to inform that policy. Do you want to talk a little bit about first your organization and your mission, and then maybe an example of some data that you've used and really seen move policy forward?
Yeah, absolutely. Thanks everybody for having me. Anna Hyde with the Arthritis Foundation. We represent the arthritis community, which is, of course, an umbrella of many different diseases within the kind of arthritis kind of paradigm. But our really philosophy for the last few years in particular has been that we want everything that we do to be led by patient data and by patient insights. And there's kind of three prongs to that. One is actually, quantitative data, which has been discussed a lot already, the storytelling for sure, qualitative data, whether that's focus groups or just, we're deriving stories from listening to patient panels and things like that. But then the third piece is vetting all of the both survey work that we do and policy positions that we may take with patient committees. So it's kind of three legs of the stool and really make sure that everything that we do is patient-led. One piece of data that I think has really given us sort of paid off in dividends is related to a project that we call Ideal Model of Care. And really the premise of that a few years ago is we know that there are all of these like issues, accumulators, step therapy, whatever, that are impacting patients, and the number of issues are growing, and so if we were going to step back and design the ideal model of care for any individual patient, what would that look like? And so we thought, well, we can't answer that question if we don't know like what the actual challenges are that patients are facing, not in this like one-off, because we do these individual surveys around accumulators and step therapy. but like, let's look at the entire spectrum of your disease journey, from diagnosis to getting on the right treatment to then maintenance of treatment, right? Through life changes, plan changes, et cetera. And like, let's ask this in a way that we're not leading the witness, because I think we all do that a lot. Like, we know step therapy is a major problem. So let's ask questions that are going to give us the answers that we want, right? So we were very careful to design a survey. It was pretty comprehensive, that talked about like what are the major challenges, and it doesn't have to just do with medication, right? Because we do focus a lot on that as well, but issues with getting diagnosed, issues with the your healthcare providers. How many providers do you even see just to manage your arthritis? It gave us so many amazing data points that I use liberally all the time, but one I would highlight is around care coordination. We knew this from just general conversation with patients, but it provided us some concrete data on the importance and the need for better care coordination for patients, and not just EHRs and interoperability of data, of information, but also I need quarterbacking. I need my providers to be talking to each other, because I feel like I am often an island trying to connect bridges, to other islands that, one is my endocrinologist, one is my orthopedist, one is my rheumatologist, et cetera. And none of them are talking to each other. And therefore I feel like I'm in this terrible bind often, where I'm trying to make actual, clinical kind of gameplays, and I don't know that. I need my provider to do that. One of the ways that that's been really helpful from a policy standpoint is when I guess it was a couple years ago, but then the final rule last year around prior auth and the the APIs and the ability for patients to be able to kind of have access to their information and more transparency around what's happening with prior authorization. And then it, when you read that rule, it speaks to all of the things that our patients told us that they need and that are important for them, and some of the roadblocks and barriers that make it so difficult to manage their health coverage. So we were able to use some of that data in our comments, and I think it just bolstered, the position that the administration at that time was taking, and then allows us just a seat at the table, and we've been able to leverage that data point in that particular issue area many times, in many settings, and that is continuing to happen, and we hope will continue to happen, especially as we try to translate that particular rule into prescription drugs. But anyway, so I'll stop there for a minute. I know we'll get into a lot more great detail. Oh, wait, one other thing. This wasn't scripted, but Amy, so funny that your data, when you said that drugs not covered and then high out-of-pocket costs are the top two, in this same survey that we did, when we asked like what are the top 3 barriers that you face, those were also the top 2 that our patients said. So it's just interesting to see across organizations when that data is like validated and corroborated. It's just a funny little little point when you put that slide up. I was like, ooh. Okay, Karen, back over to you.
No, and that brings me to a point that I hope we can explore later on about how you work across coalitions, across different therapeutic areas, because I know many of our patients are facing really similar challenges when it comes to step therapy and prior auth and accumulators and maximizers and everything that you already brought up. But before we go there, Michelle, I know the National Eczema Association has done amazing survey work, and I know in particular some of the things that were brought up by Anna and Kirsten and Amy around making sure that you validate the data and that you really have that patient voice lead your work. I know in our conversation that's something that's North Star for you all too. Can you briefly introduce your organization and talk a little bit about maybe one of the surveys or one of the data points that have really helped you push for the policies for your community?
Sure. Hi, everyone. Michelle Guadalupe, Director of Advocacy and Access with the National Eczema Association. I've been with this fantastic organization now 4.5 years. Hard to believe. But NIA is the voice of the 31 million with eczema. We ensure that they have the community resources, that they have those opportunities to advocate, as well as that really important piece on research. I've been blown away by the research that our organization has done. Really starting before my time there, but we actually have an in-house research team that they do the analysis, but before any of that happens, they do a lot of conversations. They have a lot of discussions with members of our community, whether they be part of our ambassador program or in our regular community, at different activities with our expo or other programs and events. And it really, echoing a lot of what the other panelists have said, it really kind of drives our policies forward. When I started, we had a list of, policy priorities, but we certainly have been able to fine tune them over the years. They've pivoted, they've changed, and that was really based on the survey data that we've done. It was interesting. It was like almost this exact same stat. I know this is kind of going to be maybe a recurring theme, but when you had shared that, 50% had experienced denials in the arthritis world, that was like almost verbatim on what we found in our access to treatment survey, is that they had that 50% in denial. That is an issue that I know our patients and our caregivers will talk a lot about. So it's great to know that we have that firm data. And I know we'll talk more about, how we utilize that, with our other coalition partners, but definitely have been seeing some trends amongst many of our different conditions. I did want to just take a minute. Many of you may have met Kristen so far. She was at the Bio Patient Advocacy Summit. She's been at National Health Council events, but I wanted our new CEO to have a chance just to quickly say hi and introduce herself.
Thank you. Thanks, Michelle. I will not take a lot of time because you're all talking about extremely important things and do not want to waste that time on my introduction. But I'm really happy to be here. I'm happy to learn and understand more about bio and the initiatives and activities and how NIA is involved. And congratulations to all of you for the great work you're doing. You continue to advocate on behalf of the patients. So thank you. And it's good to be here.
Welcome to the community. Thank you for saying hello and for being the fearless leader for this amazing organization.
Thank you, Karen.
So just listening to all of you, there's so many things that are striking to me. I think the first is what you already started talking about, the fact that everybody is facing similar challenges. And I know from my time in the patient advocacy community, there are always so many things to work on. So working in coalitions and joining forces is so important. I know we've talked about kind of coalition work before, and I know all of your organizations are playing immense roles leading coalitions. But I was wondering if we can talk a little bit about how you leverage data in coalitions, in particular if it is data that is maybe not directly from your therapeutic area or spans several therapeutic areas. I don't know who wants to go first, but any thoughts?
I'll jump in. Because what comes to mind right away is the All Copays Count Coalition, because that one is, very active for good reason, because accumulator programs have become an increasing problem for patients. And because there are so many both patient and provider groups that are part of that, we've been able to aggregate a lot of data sources across therapeutic areas over the years. And so when we're developing coalition collateral, whether it's, support for the Help Copays Act or just general one-pagers or whatever it is, it's good to be able to look across all of the data points that different patient groups have collected and pull out some of the most compelling or ones that just show the breadth. And for me personally, when I'm in meetings talking about this issue, I actually prefer to use other groups' data points because some of them are more compelling than some of the ones that I have for one thing. But then for another, it shows that kind of just the scope of the issue itself, right? Like I'm not just speaking on behalf of the arthritis community. Listen to this situation and this hemophilia patient, out in California had when he couldn't get his medication and ended up in the hospital, which cost over $1 million, right, to the health plan. Like, was it worth it? You know what I mean? Just to have this accumulator policy in place, like that kind of thing. I don't have that example in my kind of toolbox, but being able to draw that out because it was so compelling to me when I heard it, I think is really amazing. So that's just kind of one way that at least, for that coalition, that we kind of leverage each other's data.
Yeah, I would agree with that. Definitely have been able to use data points, whether it be in coalition letters or if you know that you are, especially on the state side, and you know you have limited time for like testimony. So when you have kind of a group, many different groups, you can kind of coordinate. You kind of know a little bit about each other's disease states and the data that they have out there. So it's been really helpful to be able to have kind of just that more broad view of really how these issues are impacting patients.
I would echo what's been said. I know we operate a coalition called the One Voice Against Cancer, or OVAC, on the appropriations side. Lots of groups in that coalition. We share data, we share information. We had a coalition around paid leave for cancer care, both for patients and for caregivers. We shared a lot of focus group and survey data. All of that data is built into letters, into fact sheets, into talking points and testimony, and even into amicus briefs that we share as a community. So having the data available to share with each other, I think, has strengthened all of our policy arguments.
I don't think I have anything more to add other than to say, agree with what my panelists have shared. We welcome receiving and hearing, listening to data from other organizations, whether they be disease specific or disease agnostic. I think the All Copays Count Coalition is a great example where copay accumulators, are disease agnostic, right? They're not focused on any particular area, so we can leverage those findings in many different ways. And that's sort of how we look at our polling at PAN as well. We don't focus, outside of our financial assistance programs, we don't focus on any particular disease. The polling that we do is disease agnostic, that can be leveraged by coalitions and coalition members.
And we'll definitely make sure that we share the links to those amazing coalitions afterwards. But if you want to put them in the chat, by all means too. I'm sure that there's some in the audience who are not yet part of these coalitions, but I know these are amazing coalitions. I think you all brought up another really interesting point. There's obviously, I think we've really shown how powerful and important data can be. But there's also cost to collecting data. There's the time, there's the impact on the patient community. And I know we usually text, again, from my nonprofit days, I know we were leaning on our advocates a lot already. And asking for service can be cumbersome, regardless of how much you try to keep the questions down. So I was wondering, for all of your organizations, how do you think about whether to do a study, how to do the study, and how do you think about what might be already out there from other organizations as you're kind of thinking through that?
Well, I've learned so much from our research department at NIA, like really how, conceptualizing maybe the topic to actually having the end result. And patients are involved in every step of the way. I can give just a couple of quick examples. Where at our expo, we have opportunities to do kind of like ambassador intensives. And our research ambassadors, they were able to kind of, have a brainstorming discussion and talk through a particular topic. And it was really made apparent to our research team that, oh, okay, well, we thought we were going to do the survey maybe this way, but based on those conversations, they had to kind of, take a step back and think through it. So I just thought I want to share that, sometimes you may think that you have a particular timeline, but then, having that important step of engaging with patients, we had to kind of take a step back. We didn't want to hurry the research. We wanted to do it right. So that was just a tiny bit of it. Other things that they do, they are involved in the actual development of the survey questions. They do focus groups. They will test the actual survey. And more, really important too, at the end, they are provided opportunities to like review some of the data, help with that analysis, become co-authors in some cases in the journal. So that's just a really quick snapshot of kind of what we look at. And for cost too, we find it's really important to have open access on all of our publications. You know, patients are involved in every step of the way. We want to make sure that they, as well as any stakeholder that goes on and sees our great work, they can, you know, review that publication in its entirety.
I think for us, the considerations are, we'll always do a quick landscape survey. You know, is there existing data out there? Are there studies that have already been done that can be used? Are there patient stories that already exist? And if there are, how can we utilize those? If not, then what is it that we want to achieve? Is it hard data? Is it a patient story? How are we going to use it? And then another consideration, of course, is always cost. Is this data something we can find free of charge? Is this something that we're going to have to create? One of the challenges when it comes to collecting stories is for every really good story that you can use, you're probably talking about 10, 20, even 30 people that you've talked to before you glean that one story. So if you're looking for 10 or 20 stories, we're talking about vetting about 100 people. That's very time consuming. It can be expensive. And as much as people are excited and want to engage, sometimes their knowledge of, if you ask them what kind, for instance, what kind of coverage do you have? Not everybody is able to differentiate between whether they have Medicaid or Medicare or do they have a Medigap. And so you have to kind of go deeper on some of those questions. So it's not always as simple as buying a data set. Sometimes it's actually creating it. And there are a number of challenges around that.
I'll jump in. You know, at PAN, we have sort of baked in our polling work, our data work into our core missions. So we know that there are things we want to do year over year that will come out of our budget. State of patient access is a good example of that. So we invest in the polling and invest in, you know, the Harris poll team, et cetera. That's important for us. We do have a pretty robust patient group who's, you know, come to PAN for financial assistance. We have thousands of healthcare providers we've worked with. So they present an opportunity for polling as well. But to your point, Karen, we don't do that often because we don't want to tire them. So, you know, we will space that out. We also think about when we're going out to do polling, we think about if there's a particular issue that is timely, that's happening, for which data will be valuable. And I'll use an example. We're seeing, you know, potentially some major cuts to the Medicaid program. So we just went out with a rapid poll around that issue and saw that, you know, 7 out of 10 people we polled were really concerned and believed that they would be impacted by these cuts. We then translated that into, okay, let's do something with that data and let's encourage patients to share their stories with members of Congress. And we do grassroots campaigns all the time. So last week we launched a Healthcare is at Risk grassroots campaign to encourage people to send messages and just share their stories. And what was really interesting with this, and unlike some of our previous campaigns, we had within the first 24 hours, we had 1,000 messages sent to members of Congress. It's way above that now, but more than 50% of patients took the time to share their stories and share their concerns, which was phenomenal. And, you know, anyone who reads stories will, you know, have a tissue box next to you. These stories are heartbreaking. So it's again, going back to your question, it's what do we think we need to do as an organization year over year to drive policy and education? And of course, there's initiatives where, you know, external funding will be needed, and we seek those opportunities as well.
I don't have anything to add because I think the other panelists covered all of the points I would make. So I'll just kind of double down on one for each, which is the landscape review. I think is really important that Kirsten mentioned. The open source piece that Michelle mentioned, also super important. I think that's critical and certainly a barrier to, I think, many organizations being able to just seek outside data. And then from what Amy said, that sometimes it is a trade-off where we're fortunate to have an in-house team who can do a lot of our survey work. But if we do want to have an outside data set, which we do think is really important to bolstering our data, in some cases, it often does rely on grant funding in order to front the cost because it is expensive.
That makes sense. And I'm already seeing questions in the chat. So I do want to make sure that we will get to questions from the audience. I think this is a really central part for many on the call today. But I do have a follow-up question. In particular, in recent years, we've seen kind of the access landscape evolve pretty quickly. For instance, around accumulators and maximizers. A few years ago, I don't think anybody had heard of them, and to see like how quickly things have changed. How do you think about like the life cycle of the data? When is the data outdated, or when do you know whether it is outdated? When do you have to go out again? And I know for some things like Amy, your annual survey is already baked in, but just curious.
That's a tricky question. I was thinking about this one. Because we also do a biannual priority survey where we're able to benchmark, which I think is really important at certain questions. And the two critical ones are, what are your top arthritis related challenges? Spoiler alert, pain comes up as number one every single time. And then what are your arthritis care related challenges? Prior auth comes up number one every single time. So it's kind of interesting. So for benchmarking, that's really helpful. But for digging in deep, where you want to do a single issue survey, you do have to kind of think about when is the right time to kind of go back at this. Accumulators, you brought up that as an example. We did a survey in 2017. So that's kind of old at this point. However, if you look at the actual data points in the questions, I think a lot of them are rather evergreen. What would you do if faced with a large unexpected charge, for example, right? 84% said that would cause me significant budget problems. I don't anticipate that number would change very quickly. So it's more in terms of like how many people are being impacted by that issue. Is that something that we can roll into our biannual, survey where we don't need to dig as deep? So it's a constant kind of discussion almost and kind of trade-off. And again, relying on outside literature, because sometimes we're really fortunate and Avalere will publish a study on some sort of impact on rheumatoid arthritis, specifically on step therapy, which is great. It's like I can grab that data source and maybe that buys me some more time before I need to go back, and pull my own, group about this.
Yeah, we did a baseline access to prescription treatment. It's been a bit. It's 2021. We're actually looking at doing our 2.0 later this year. Because really, in many of our different disease states, they've been changing, quite considerable. That's the same with eczema. The treatments that were FDA approved in 2021, we have many more now. So we want to be able to have some of the benchmark questions that we've had in the past, wanting to see too, like, are certain of these classes of treatments, are they having a harder time accessing, or what has been kind of their experience? So I would say too, yeah, we're still, before starting the 2.0, looking at landscape, seeing what articles are out there, definitely looking at all of you and what you have been able to publish. All of that kind of goes hand in hand with getting prepared to do our survey later this year.
The only thing I would add is that qualitative research might be, it's not always ideal, but it might be a way to, in absence of being able to go out with another poll, to validate or to hear from patients. So, we have a patient and family advisory council that gets together very often. They're a sounding board for us. We can run things by them, but we all have patients, we all have healthcare providers where, convening a focus group might be a relatively easy thing to do, to, ask some questions that are timely.
Yeah, I would agree with all of that. And particularly, I think Amy's point is really well taken. You don't always have to do a massive survey or set of focus groups. Particularly if you're saying to a policymaker, we brought together some of our top grassroots or grass tops and ask them these three questions. And we're sharing this with you anecdotally so that you're not selling it as statistically relevant, but it is still the stories from their constituents.
Fantastic points. Again, I'm looking at the time. I want to make sure we have ample time for Q&A. But based on everything that you've heard, I would love from each of you to hear what is your favorite data point or most impactful data point, and what do you think are the biggest access barriers that patients are facing, and kind of like what data is most compelling as you are having these conversations on Capitol Hill and beyond.
Well, I'll jump in on that one because I guess I would call it a landmark survey study for us was several years ago where we did a study, ACS did a study that showed that people without insurance get diagnosed with cancer at later stages when the prognosis is worse and the costs are higher. And it was that study that was the impetus for ACS and ACS CAN to support healthcare reform, to support the Affordable Care Act. And we were able to use that study to say not having insurance is the biggest barrier to healthcare. And that barrier to healthcare can actually cost people their lives. So we've updated that study in the last few years, and the findings are still the same. So for us, that's really foundational.
That is so powerful. Who wants to go next?
I'll go next. I think that's a really good point. I had already mentioned, how much I love using that hemophilia example because it's just so outrageous. You know what I mean? It's like you just can't even make that up. So I use that often, but in terms of my own data, I think I would just go back to that benchmarking over the past. I'm trying to remember when we started doing that survey. Let's say it was 2017. We started doing those at that time. It was annual priority surveys, and the fact that we can say going back to 2017, prior auth is the single biggest care barrier that patients are facing. That longevity of that data point, I think, makes it more powerful and also really helps us to combat some of the misconceptions that happen specifically with prior auth as an issue. I cannot tell you how many meetings with policymakers I've been in where questions come up such as, do patients even know when they're being prior auth? And so you can say, well, actually they do, and this is how I know that. And then of course, having the specific examples, I think I always couple a data point with a story, and it's usually the most recent story I heard on that issue from a patient. So I think that's really powerful.
I'll jump in. For us at PAN, it really is the grade C that patients give access to care in the United States, both last year and this year. And the reason why, and I always like to say, a C is not good. If you brought home C's, when you're in high school or college, your parents wouldn't like that so much. It's quite an average score. And just as an aside, we polled adults living with chronic conditions, but we also oversampled, which is really important, expensive, but it's important because then we're also able to look at different communities. How do people who identify as LGBTQIA rate access to care? And the grades were much worse. But what the State of Patient Access does for us is it opens doors to be able to talk about a whole range of policy concerns, from high out-of-pocket costs for prescription medications, all the challenges that people face through their healthcare plans, the importance of clinical trials and diversity in clinical trials, medical debt, and so on. So it opens the doors to many different kinds of conversations.
Yeah, so at MIA, the research we do is still relatively new. It's really been since 2019 that, we've had such a fantastic in-house research team. They've, been able to survey our community. We've had, so many different uh, research studies, the like, that have came out of it. One that happened like right before I joined, and they were doing the survey analysis as I was coming on board at NIA, was about out-of-pocket costs, but not just prescription out-of-pocket costs. They wanted to have a better understanding of how, just the whole experience for the patient. In eczema, like many others, it can be a pretty expensive in terms of, what is covered by prescription, what are those out of pocket over the counter type expenses. We were seeing that 42% of our respondents, they spend upwards of $1,000 every year on prescription, over the counter, the like. And I'm sure this wouldn't surprise you that, the worse your condition is, the more expensive it is. So it's always those double, triple whammies that our patient communities go through.
Fantastic. Before I open it up for questions, and again, I already see some in the chat. Last question for patient groups that are that are in the audience today. What is your advice? Where can they go if they want data? Or what is the one piece of advice that you hope that they will take away from the discussion today? In particular, if they're newer to using data for
Well, I think, fellow patient organizations, we all have a lot of trusted resources. For us, we might look at like a JAMA or a PubMed, just to really kind of have that landscape, just to kind of get us a sense of, what is happening in the field, and see if what would mirror what's happening in our own disease state.
Yeah, I would add one cautionary note, and that is we've been very comfortable using government data, the free data sets. And with all of the information being withheld right now, I think just making sure that you're approaching these new data sets with a certain amount of caution and skepticism, and just verifying that.
I think all the patient groups have a lot of resources to share. I agree with you, Michelle, and everyone should be encouraged to leverage the good data that we're putting out. I love that point, Kirsten, and I think it's critically important. I rely a lot on the Kaiser Family Foundation, the Commonwealth Fund for great data as well. And I guess the only other point that I think we've all made is to sort of marry the work that you're doing on collecting data with the patient stories, because it's really powerful together.
I agree with that. I would double down on something Kristen said earlier, which is that it doesn't have to be a really formal resource and labor intensive survey. You can do more informal polling, and we similarly practice just radical transparency about that when we're using that kind of data to say this was just a poll of so many people. It's not statistically significant, but gives you a snapshot kind of thing. I think that can be really powerful. In terms of outside data sources, in addition to what everyone else has said, which I think are great ones, the Congressional Research Service is great. And CBO, as much as we like to complain about methodology, so it's like you have to kind of use that carefully. But sometimes those data points too, right? Looking for kind of nonpartisan data sources, obviously depending on the issue that you're working on, that may or may not be relevant. But there are a wealth of resources out there like that are, highly sort of credible and respected.
Fantastic. Anybody in the audience, please use the raise your hand question if you have a question, or put it in the chat. The first question that I saw in the chat already is around the use of AI-enabled tools for research, and if any of you are using this new frontier. Any thoughts?
We actually haven't dipped our toe in that yet.
We have not either.
I haven't personally, but I bet there are people in my organization who have. So I don't think I'm a good representation of that from my organization.
I would echo that, Anna.
That is very fair. Any other questions from the audience? And while we wait, Tiffany, I see you on the call. I know you've also done a lot of work, in particular, collecting patient stories and helping to collecting curate patient stories. And I know you're working on an issue in Oregon right now that I think is really interesting. So I don't know if you want to come on camera and want to say hello to everyone. Sorry
Yeah.
to be calling on you, but
That's all right. First of all, great discussion. And, this is for those who do or don't know me, this is my passion. Research to data to drive public policy is where my heart is. So when I saw that this was the topic, I was like, yes, I'm there. But great job, everyone. And, I can't second enough the great conversation and the points that were made. So I'm the original founder and CEO of AI Arthritis, which is short for International Foundation Autoimmune Autoinflammatory Arthritis, but also the founder and lead of a national disease agnostic coalition that's addressing the government drug affordability review. So that would be the Prescription Drug Affordability Boards, or PDABs, and also CMS IRA. We are a unique coalition in that we have the unique patient organization and allied groups side, which is called the Ensuring Access Through Collaborative Health, or EACH. And then we have the Novel Patient Inclusion Council. And so shout out to Vanessa Lathan. I see that she's on here as well. She's our new lead of the Patient Inclusion Council. In saying that, as all of these reviews started pretty full force there in 2024, with my background in research and as a patient research partner myself for about a decade, the first thing I noticed was, wow, these surveys are poor. And maybe that was by design, because they were not capturing any information on the affordability why. There was no context. The questions were poorly designed. And so I reached out to some fellow patient research partners on the PIC side and EACH. Anna was one of them. And so there were several patient organizations, and we came together and said, we need to create the right survey. And so we published a pilot last year. We had 104 responses, and this is a 20 to 30 minute long survey, unpaid. So the fact that we had such great, robust, really just shows you when a patient cares so passionately about a topic and having their voice heard, the participation can be there. We also told them that their patient peers would be reading these answers, and would they be willing to have continued conversations. And so we were very happy that 75% of all of these people who responded gave us their contact information. And so we are following up. So there is a lot of qualitative to go with that as well. And so with that, we have just relaunched the new survey, and we encourage anybody who is affected by these. And that also means people who are not necessarily on the drugs under review, because they are focused on therapeutic alternatives and drug classes. So that means even if the drug isn't there, if your disease class is classified under that drug, your other drugs are potentially going to be related in some way. So this is a very, very vital survey for everyone to get involved in nationwide. And then as far as Oregon, Colorado, some of the specific, even CMS, the specific asks, what we are doing is, in order to get more patients involved in data collection, instead of just directly sending them, for this example, Oregon PDAB has 27 drugs up for review. They need patient information by the end of April. So we could just send the survey link over to patients on social media, etc. But the survey is not good, first of all. And second of all, we have no way to follow up. We have no way to know if they've taken the survey. We have no way for continued conversation, collecting stories, getting them to potentially testify. So we have developed a catch-all page where PIC voices, or patients and caregivers from around the nation, can fill out this quick form. Patients are on the other side waiting to say hello and respond. We then give them the Oregon survey. We check up, we follow up. Hey, don't forget. So there's that process in there. And then also, as they do respond and say they do it, then we give them the link to our larger survey. We give them opportunities to participate as patient research partners, to watch webinars, to get involved in discussion groups. So it's really kind of focusing in on that peer-led research. So that's what we're doing. I'm happy to share that link they're okay, Vanessa's on it. I see her posting things in the chat already. So she just posted our pick voices. That's the one for really any of the opportunities that we have. And then we also have one specific that goes to the survey.
That is fantastic. Thank you so much. I'm sorry that I was calling on you,
That's
Tiffany.
okay. I'll talk about this all day. My favorite topic. Thank you.
Any other questions from audience members? Otherwise, I do have a question for you all, in particular with what Tiffany just said. How do you find, I mean, I know you're already working day to day with a lot of patients, but how do you find patients for surveys, and like what are some of your best practices and experiences? Understanding, Kirsten, as you said, finding that right story and that right intersection can be like finding the needle in the haystack.
So yes, absolutely. So we have a couple different sources. We use our volunteers. We'll sometimes call out for volunteer stories. We also, in the Survivor Views project that I mentioned, this is actually a cohort. So we went through recruiting just like anybody would recruit survey participants. So those are two avenues that we use.
Yes, so we utilize social media quite a bit in terms of reaching community members to do surveys. We also utilize our ambassadors. We had started a few years ago, kind of a boots on the ground campaign, where they are out going to like community health clinics, healthcare provider clinics, just try anywhere there's community, and really kind of talking through like our resources and then being able to engage them into our broader efforts.
We leverage social media as well. We also have a monthly patient newsletter that goes out to many, and from time to time we'll include polls in there, and we get a pretty good response from that. And storytelling is just a major focus of ours. So, for example, every time we go out with a grassroots campaign, maybe it's around step therapy, maybe it's around telehealth, we'll add a storytelling component to it as well to generate these stories.
Nothing to add on my end from that standpoint, but I will raise a challenge, which Tiffany and I have talked about a lot over the last couple of years, which is that when it comes to things like BDAPs, which are so wonky and technical, it can be really hard to find patients to engage. It's not that there aren't patients who are impacted, it's that it feels so removed from their daily life, right? It's something the Department of Insurance or whoever it is working on. It has to do with these economic concepts that just really are not relatable to the everyday person. And that's something that we have struggled with and haven't completely solved for, but it's instructive when you do send a call to action out to your Colorado patients and you only have 3 of them respond back, and are interested in engaging. Okay, well, that tells us something and we need to kind of solve for that and work through it. So we haven't quite gotten to the right formula yet, but I would just flag that as a challenge that isn't completely solved for yet on our end.
And I see a lot of head nodding there. I know from my own experience, the wonkier the survey and the more removed from daily life, the harder it is, even for myself, to sit through and take the time that it takes to answer a survey. Any last thoughts? Otherwise, I know we're at time. This was a fantastic conversation. I learned so much. Thank you for everybody who put links in the chat. We will make sure to follow up with links to all the resources that were referenced today. And just thank you so much to my wonderful panelists and to everybody who was on the coffee chat today. Have a wonderful rest of your day.
Thanks, Karen.
Thank you.
Bye-bye.